cervical disk pathology. The objectives are we're going to tell you the impairments and functional limitations that come with it, and also the interventions you can do for those functional limitations and impairments. So, a quick overview of what it is. It refers to degenerative or traumatic conditions that affect the intervertebral disc of the cervical spine and can cause a disc herniation and or nerve root compression. We're talking about decreased, the impairments we're talking about today are decreased muscle strength, range of motion, and poor posture. All right, so according to Dutton and a source I found by Eubanks, I believe it was 2010, the most commonly cervical disc herniation is about the C6, C7 area, which can cause a nerve root compression of the C7 nerve root. So that's kind of the route I took for my decreased muscle strength slides, and we all know that nerve root compression of C7 is for elbow extension. So for the maximization phase, I have my patient seated. And in this phase, you want to isometrically contract the triceps because you don't want to aggravate that nerve root some more. So what I would do, I would have my patient with their elbow on the table like this, and I would tell my patient to basically pretend like they're trying to push their elbow or push their arm down, trying to extend their elbow. Hold it for about 2 or 3 seconds, and you do about 10 repetitions, maybe 3 sets to 10. You feel your triceps contracting? All right, good. All right, so once they get to about 10 of those in the motor protection phase, I can do what we call a wall tricep push-up. I can show you what that is as well. Follow me. From a regular wall push-up. So we come to the wall, elbows to the wall, wall push-up. In this phase, we'll start actually concentrically contracting our triceps, concentrically working our triceps, where in the max rotation phase, we didn't do that. You feel triceps working? All right, we'll probably do about 3 sets to 10 of those. All right, that's good. In the minimal protection phase, you can do all types of things. It depends on your patient, whether they do for a living or ADS specific tasks. For my presentation, I just showed something as simple as a tricep dip, but you can do a tricep, pull down, and overhead tricep extension. It just depends on what you want to do. So for this one, I'll show you first. Just do a regular tricep dip. And I'll probably do about 3 seconds of those. The triceps working. Great. All right, good. Those are pictures of them.
Alright, so for our second impairment, we went with decreased range of motion. Within the first phase, we're going to focus on passive range of motion. This is to help with getting mobility and strength back within the spine and strengthen those muscles there within the neck, because when you have decreased range of motion, it does, according to Dutton, it said that decreased range of motion can be another impairment because it is lowered in the direction of pain, with rotation being one of the ranges that causes pain, and some of the other ones it mentioned like extension and side bending, and this can occur going towards the root or going away from the nerve root if a nerve root is involved. And so for the maximum protection phase, I'm going to have my patient come lay down on a table for the passive range of motion. And this is to also help, as again, I can just increase function within the spine, help like improve blood flow, strengthening the muscles, and other aspects like that, and bringing oxygen back to the joints from one of the other sources that I have up there. I believe it was number 7. So what I'm gonna have my patient do is, if you'll scoot a little bit more towards the edge of the table for me, so I can grab your head. So you're just gonna rotate the head to the side and hold it for a few seconds on one side. Come back to neutral, and then rotate the head to the other side and hold that for about several seconds. And you'd want to do this like several times. I'd say maybe about like for maybe 3 sets of 10 or so, and hold for like several seconds each. And then so you can sit up now. Did that feel all right? So then for the next phase, I'll have my patient do I don't have any towels, but we can use a sheet and roll it up, so because this will be an active assisted exercise where you're using like a towel to help with also continuing to increase range of motion, and this helps to improve rotation as well. You'd want to do about 2 reps of 10, 2 sets of 10 reps of this. So what I'm gonna have you do is I'll have you put this around your neck, and then you're gonna rotate to both sides with it and hold it for a few seconds and perform it for maybe about 2 sets of 10. Hold for about hold for about 3 to 5 seconds. And then switch to the other side. Okay, you feel a difference? For our last phase, for 12 weeks plus, I'm gonna have my patient be in the quadruped position on all 4s. This helps to still further increase motion and restore range of motion to the rotators within the neck, mainly the deep rotators, so like your rectus capitis, posterior major, oblique capitis, superior and inferior, and the splenius group. So to have my patient perform this one, he's going to be on all 4s, and I'm going to instruct him to tuck his chin in towards his neck, kind of going into extension, and then you're going to just slowly rotate your neck to both sides, and you'll perform this for about 3 sets of 10, hold for about 3 to 5 seconds for each. Okay, so I'll go with that one. And then for our last impairment, we focused on poor posture in the spine. This is mainly one of the things that patients can have with cervical disc pathology is that they can develop a forward head posture, and what happens here is that the anterior deep cervical neck flexors will be lengthened, which would mean that they'll be weak eccentrically, and then the posterior cervical muscles will be shortened, so they're weak concentrically. So the goal of this part is that you want to focus on lengthening the muscles that are shortened, and lengthen and focus and getting them back to their proper positions, which is why the rationale for this is to strengthen those. So because with some posture things, and Kisner has you want to focus on proper body mechanics within the workplace, because say if you have somebody that is working at a desk all day, they could develop that forward head posture, which causes the muscles to get weak. And it did mention There's a table in Kisner in chapter 14 that talks about some of the different things about that. Just one of them, for example, is just making sure just to set up your workstation at an appropriate height to keep your joints within neutral. And so from there, for this exercise, we're going to focus on chin tucks, because with the forehead posture, this is going to occur around about like C5 to C6, C6 to C7 for them being effective for the muscles there, because that's also due to weight being put on the zygophysial joint. So for this exercise, I'm going to have my patient lay in supine on his back. And then also, if you'll bend your knees up for me in the hook lying position. And so what I'm going to instruct my patient to do is you'll just tuck your chin in towards your chest. Do about 3 sets of 10. Hold that for about 3 to 5 seconds. Okay. And then does that feel better? Alright, so for the next exercise, we progress this to sitting chin tucks. This is still going to be targeting your different deep cervical flexors as well as the SCM, sternocleidomastoid, and scalings. When you get to this phase, it helps to further educate the patient on putting their neck into neutral. So I'll just have you still do a chin tuck here, and bend your neck down, and then do this also for about like 3 sets of 10. Hold for about 3 to 5 seconds. Alright, so we move on to the next phase. So for the minimum protection phase, and because the last phase was also working like with gravity, this one also is going to work against gravity. So this is still continuing to focus on the cervical neck flexors, mainly more the longest coli, but it still targets the other ones as well. So to perform this exercise, I'm going to have my patient get on the mat in the quadruped position, and then I'll have them place the band around his neck. Push back into the band and then go into flexion, then an extension. And then he would do this. Some sources I found said about like 2 sets between like 15 to 20. One source said hold for about 30 seconds, but I would say use your clinical judgment for this. So hold maybe anywhere from like 15 to 20 seconds or so for each.
Contracted, doesn't that mean that there's weak eccentrically? Or no? I might have that wrong.
So let's think through this a little bit.
Yeah.
Right? So when we talk about forward head posture, what does that position typically do? Liz told us, right? We go to forward head posture. What happens to these anterior deep cervical flexors? What position are they in? They're elongated, right? Okay. Then what happens to the muscles posterior? Okay, and also the SCM, what happens to those muscles? They're shortened, okay? So if I have a muscle that is shortened, okay, or let's talk first on the deep cervical flexors. If they're elongated, they can't work through their full range, right? So a concentric contraction does what? Shortens, right? So honestly, both muscles are probably weak, both concentrically and but we're probably going to do something posteriorly that's going to try to stretch or elongate the shortened muscle, and then also strengthen, okay, the weak muscle or the elongated muscle. Try to shorten, strengthen, probably concentrically first, but you're also going to be wanting to strengthen it eccentrically because you need to be able to strengthen it through the full range, both ways. Does that help, or does that just muddy the water?
Oh, I'm just thinking like, okay, when a muscle is pathologically shortened, that means that they're weak. Well, I thought that it meant that they were weak eccentrically because they can't elongate.
Yes, that's accurate.
That's, yeah,
That's accurate.
okay,
I would say that's accurate.
okay.
And so then there's a couple different schools of thought. Have you ever heard of Shirley Sauerman? Ever read anything from her? So there's different approaches to this, right? She said in a muscle imbalance, this is one type of muscle imbalance. Okay, Dr. Carter threw out the name Vladimir Yanda the other day. Okay, I had to pretty well memorize this old school Vladimir Yanda article. Right, but he talks a lot about muscle imbalances. Forward head, we see that. Lengthen here, short here, okay? Then up here, tight anterior chest muscles, pec muscles, weak, lengthened posterior scapular muscles. So with this person, we want to, Vladimir Yanda would say, you need to stretch out the tight muscles and follow that by strengthening the weak muscles. Okay, that's his approach. So stretch the pec, strengthen the scapular retractors. Okay. Shirley Sauerman would say, well, actually, we should just strengthen the posterior muscles, and that will address the tightness on the anterior side. Interestingly, they probably both have good results. So, what I'm trying to say is, you will see different approaches to a lot of different things, and you're going to try some things, and some things are going to make more sense to you than other things, and you're going to find yourself going that direction. But it's not necessarily that there are a lot of ways to get to the same result. It's just like somebody who's lacking lumbar mobility. Right? Williams, you ever heard of Williams flexion exercises? Right, where you're doing pelvic tilts, knee to chest, double knee to chest, trunk rotation is pretty standard, right? When I got out of school, I got one day of that in PT school, orthopedics. I remember he talked, he wasn't even doctor then, Phil Anlawagi. He talked about one day about Williams flexion. He gave us a handout. He said, here you go. On the same day, he said, here's a handout on McKenzie's extension. He said, you'll see it out there, right? Repeated motions, McKenzie's extension protocol. And then we learned all this other stuff. And I got out there, and I had an old school therapist that I worked with. And all she ever did with her patients was Williams flexion. It didn't matter if they came in with disc pathology, if they came in with like lumbar stenosis. It didn't matter what it was. This is what she did with all her low back patients. And I thought, gosh, I can't just do that for everyone. But here's what I noticed. A lot of her patients got better. And I thought, whoa. Like, now, not all of them. Like, some of them really needed some other things. But what I'm trying to say is there is some value in a lot of different techniques and things that are out there, okay? So I think the first line of thought for me, from my experience, from what I've read, I tend to follow along the Vladimir Yanda approach. And when I see these muscle imbalances, he calls this the upper cross syndrome. If you ever see that term, upper cross syndrome, tight pecs, weak or lengthened scapular retractors, okay, tight posterior cervical muscles, weak anterior or lengthened, and weak anterior deep cervical flexors. They call this upper cross syndrome. Lower cross syndrome would be tight hip flexors with weak glutes, okay, weak hip extensors. At the same time, an elongated abdominals that are weak, and tight lumbar extensors, rectus spinae muscles. So, and you've all seen people like this too. Now, all of this feeds into their pathology. What was their pathology and condition? Cervical disc pathology. And so, I talked with Liz and Trey about this yesterday. One of the biggest problems in a person who has disc pathology, whether it's cervical or lumbar, is what type of stress on the spine? Compression, right? So if you think about these muscle imbalances, do you see how if I have tight posterior muscles here, or tight posterior muscles here, and even the hip flexors come in, we talked about when we did the psoas release, comes in, attaches to the spine, and when they're tight, it compresses. What's that do to the disc? Compresses the disc, right? So if you have a pathology of the disc where you've got some weakness in the lining, that's going to exacerbate those symptoms. Whether they have nerve compression or not, it's going to bring their vertebrae closer together. And I talk about this education with patients a lot too. Right, so we've got these discs between the bones, the vertebrae. And if we have disc pathology, what happens typically to that size of the disc? What happens to it? It shrinks, right? It gets a little smaller. It gets compressed. And when it gets compressed, the bones get closer together. Then when the bones get closer together, guess what happens to the foramina? Okay, the opening where the nerve exits. It's smaller, right? It's kind of stenotic, narrows, it gets smaller. The other thing, look at the facet joints, the zygapophyseal joints, right? What happens to them when we get compressed in those discs and the bones come closer together? What happens to them? They get closer, is that what you said, Kendall? Yeah, they get closer together. So guess what happens when bones get closer together and they're rubbing against each other? What does the body do to, when it has chronic stress in an area, what happens? Okay, what would you say? Contraction. You may see contraction of muscles. A lot of times the contraction of the muscles or shortening of the muscles will increase this. But when a body has chronic stress in an area, you get increased tissue. The body responds to stress by producing more tissue, right? If you've got a tendon that's constantly pulling, right? Osgood Schlatter's. Tendon is pulling at the bone. Who in here has a knobby knee? Tibial tuberosity. Somebody. Okay? Right? Because your tendon was constantly pulling at your tibia, and the tibia responded by laying down more. There was calcification, and now all of a sudden you've got thicker tissue. Well, when you get thicker tissue here, what develops? Like a bone spur, right? Or thickening of the ligaments. And now, when we talk about our bones are closer together, our neuroforamina are smaller, and now we've got thickened tissue that's also taking up space. Guess what has a lot less room to move? The nerves, right? So you're much more likely to compress a nerve and see something where you may get a radiculopathy, a C7 radiculopathy. We say that often up here, right? But understand that, and I think it's really helpful to educate your patients on that as well. But that's a big problem when it comes to disc pathology, is the compressive stress. So there's nothing. Is there anything we can do to make their discs nice and fluffy again? No, right? Is there anything we can do to get rid of the any bone spurs that they might have, or thickened ligaments that they might have? No. But what can we do to address their compressive stress? We can use distraction, right? So that's a technique. You guys are learning these manual techniques for distraction. Okay, what can we do with, you guys have told me, or maybe we've talked about this together, that the muscles, when they're tight, they can increase compressive stress. So what can you do to address the muscles? Stretch them, okay? Decrease the tone if there's increased resting tone. All of that's going to have the effect of decompressing the spine. Now we talked about another thing. What do we talk about that they could do position-wise, okay? Liz did a good job talking about and addressing postural habits and stuff. So what position, and I know we had this conversation yesterday, but what position tends to be the most problem for increasing compressive stress? Standing or sitting? Sitting, right? So a lot of people have sitting jobs. You guys sit all day long, right? Studying. So when we're sitting, we got the effects of gravity pushing down and then compressing against that stabilized pelvis, right? So that's going to increase that. So a lot of times I will even educate patients on decompressing by laying down. So if you think about it, all day long, gravity's compressing the desk or the discs, and I will tell my patients, I'll say, listen, if you've got a spot in your office or if you're working from home, if you're really just starting to feel the effects of those symptoms and you have the ability to go lay down for a minute, lay down. 5 minutes to 10 minutes can allow a little bit of fluid to flow back into those discs, right? Because they're compressed, and then they lay down, it's like, get their legs propped up. What's that going to increase? Flexion, which is going to do what to the neuroforamina? Open them, right? So we open them up, let them lay there 5 to 10 minutes, propped on something, not holding their legs upright. And that's going to help to decrease that compressive stress as well. That can be very effective. 5-10 minutes might help them go from being miserable in the afternoon to being able to make it through the rest of their day. So if they don't have a place they can do that, like at work or wherever they're at, then I'll say when you get home, first, if you have the ability, sometimes you do, sometimes you don't, lay down 5 minutes, prop your legs up, okay? And see if that doesn't help to decompress that spine, okay? So understand that, keep that in mind, and then they did a good job with the impairments that we often see develop because of that. But I want you to have that understanding, and when we're talking about discs, we got to do things to reduce that compressive stress, whether that's patient education, techniques that we can use, but really addressing the things that increase compression through that spine as well. Okay? Anybody else? I took a long time answering Tia's question, your question. Anybody else have questions?
I have a question. When Trey was doing the resisted, I guess, cervical extension, what did you say that was for again?
That was when he was using the band,
Yeah.
quadruped, that was to help with his forward posture, was like to help with the forward head posture at the end, cause like it helps like to restore more strength back within the deep cervical flexors, especially like the longest coli from what I have found in research.